Now we'll go on to single ventricles. So now what we're going to do is talk a little bit about the pulmonary atresia and intact septum and tricuspid atresia in a little bit more detail. And Anita did such a wonderful job talking about hypoplastic left heart. Today I'll go into some of the other functional single ventricles and not dwell on hypoplastic left heart, because she certainly did an amazing job. So we'll talk about the overview, the surgical palliation, the classical single ventricle variants, and functionally single ventricles, and then some pre and post comorbidities of hypoplastic left and hypoplastic right heart, which our group has just recently submitted for publication. So when we think of single ventricles, we think of those classical single ventricles, which are pulmonary atresia, intact septum, tricuspid atresia, and hypoplastic left heart. The true classical, from a cardiology standpoint, single ventricle is what we call a double inlet left ventricle with a small outlet chamber, and we'll show some pictures of that. These classical single ventricles comprise about 8% of all congenital heart disease. We also have functional single ventricles, that is ventricles, hearts that have what look like two ventricles, where you think you'll be able to do a biventricular repair, but for some reason, usually a problem with the AV valves, you aren't able to do a biventricular repair, and that includes severe neonatal mitral stenosis, Ebstein's anomaly, as we've seen, critical aortic stenosis with severe endocardiofibroelastosis, that is scarring of that left ventricle, double outlet right ventricle with large uncommitted VSDs, double outlet right ventricle and mitral atresia, and a very severely unbalanced AV canal defect or AV septal defect. So each of the single ventricle groups, if you think of them as, once you've gotten beyond diagnosing a single ventricle, either classical or functional, then to know what to counsel the parent, you really have to look at the outflow tracts. And it's the outflow tracts, not the ventricles, that really determine what type of postnatal surgery you're going to have. So if you have decreased pulmonary blood flow for any reason, the baby will either have a Blalock-Taussig-Thomas shunt, as you see here, and this is Helen Taussig, who many of us, well, all of us really admire. She was at Hopkins in the 30s and 40s, and really was the person who kind of sat down with a napkin like Wayne and drew out the Blalock-Taussig shunt, which it wasn't called then. Vivian Thomas was the person who worked on the dogs to prepare the shunt and did the early experiments with it under Alfred Blalock's guidance. And if you are ever looking for a really good movie to see, something the good Lord made is a story of the three of them, and it's just a really wonderful story. So the idea of the Blalock-Taussig shunt, Thomas shunt, is that you would interpose a Gore-Tex graft from the innominate artery into the pulmonary artery, so that when the blood came around the aortic arch, some of it would go through that Gore-Tex shunt and provide pulmonary blood flow to the child. There were lots of disadvantages. Obviously, the shunt didn't grow. There was kinking, there was narrowing, all sorts of things. But it was really a spectacular day in pediatric cardiology when the first shunt was put in and was successful. If, on the other hand, you have normal pulmonary blood flow or even excessive pulmonary blood flow, and your problem is decreased systemic output, the first step is not a shunt, but a Norwood procedure with a BT or a Sano shunt. Right? The problem is there's decreased systemic output, so you have to do a graft here to increase the size of the ascending aorta. And then you cut off the pulmonary artery here because it's become the neo-aorta. So you have to put in a shunt, either a Blalock-Taussig-Thomas shunt or a Sano shunt, which is a valveless conduit from the right ventricle directly into the pulmonary arteries, and that's the Sano variation. The Norwood, of course, is from Bill Norwood and happened as early as 1980, and I will date myself here and say I was a fellow at that time, and at that time, before the Norwood procedure was established and perfected, nobody came out of the operating room, but now about 95% of babies do come out of the operating room. The second step, whether you've had a BT shunt or a Norwood, is providing adequate blood flow because remember you've had either a Sano shunt or a BT shunt to the lungs, and that is a natural shunt, which is comprised of the SVC, which is taken off of the atrium and placed instead directly into the pulmonary arteries, and that's called a bidirectional Glenn after Dr. Glenn. The final procedure is the Fontan procedure, named after Dr. Fontan, and that consists of hooking up the IVC and the IVC, so that blood runs directly into the pulmonary arteries as well. So the circulations then are effectively divided, and all the blue blood goes to the lungs and all the red blood goes to the body. So common to all of those who have a decreased pulmonary blood flow is a reverse ductal shunt. And these are some examples here. Here we have a pulmonary atresia intact septum, a very small right ventricle. We see the aorta coming from the left ventricle. And then here's the ductus wrapping around, having retrograde flow from the aorta to the pulmonary artery. This is another view showing the retrograde flow in the ductus. And then right in here, that's a pulmonary vein, this kind of greenish here, and then you can see it just briefly coming off the underside of the arch. So we talked a little bit about how obstruction developed. These are just some other, so I won't go through that again, but basically it can be from not enough inflow or not enough outflow. The hallmark is the reverse shunting, and you can see in your 3-vessel view, you can see that the color is wrong, that you'll have retrograde flow in your pulmonary artery, depending on which way you're showing your 3-vessel view. All right, tricuspid atresia we talked about a little bit. I'll show you some more examples, also from this different from this morning. So here's our little right ventricle here, the big VSD that we talked about, and then the normal sized left ventricle here. Notice how large the patent foramen ovale is. Here's another view showing again the size, showing the pulmonary artery coming across from that small hypoplastic chamber. And remember how the pulmonary atresia intact septum chamber looked, right? It was really hypertrophied and not moving a lot. This is moving pretty well. Then you can also have transposition. So here's your left ventricle here. There's your VSD. And you see that the pulmonary artery is the larger vessel coming from the left ventricle, and the aorta is this little small vessel here. And here's another view to prove it, to show the branching here, and then the small aorta here. So this is the only time that you will have a hypoplastic right heart, but undergo a Norwood procedure. And we talked about this too, so I'll skip over that. So we talked a little bit about the problem with the coronary arteries and pulmonary atresia intact septum. This was a quote from 1783, and boy, the pathologists sure knew how to write then, didn't they? When we couldn't do anything about it, we were much better descriptors than we are right now. But this was a child who was born and then was died on the 13th day of life, and the pulmonary artery was found to be entirely impervious. The septum was entire, and the right ventricle had scarcely any cavity left, while the left ventricle was large and powerful. So when we think about the right ventricle, we think about it as a tripartite organ. That is, it has an inflow, which is related to the tricuspid valve. It has a body, which is a major big part of it. And then we have the outflow tract. And in pulmonary atresia intact septum, any part of these or any combination of any part of these can be small. So here's some examples of pulmonary atresia intact septum. I'm sorry, this is slow. This baby was not bradycardic. But you see even here at 15 weeks, yet how small the right ventricle is here. You can also see how small the pulmonary artery is that crosses down here compared to the big aorta that comes from the normal left ventricle. Now, the other interesting thing, and sometimes you have to look at things a few times, and I find myself going back and looking at some studies from years ago and saying, "Oh my gosh, I never noticed that," but there it is. But look at the brightness in the endocardium of this left ventricle. My guess is that there was already some coronary issues for this baby. Here's another baby with the same. That view isn't really quite clear, but here it's clear, much more clear. And you can see how very early on you can really see that this is a hypertrophied high-pressure chamber, and there's no VSD, while the left ventricle is normal. Even if you look at the aortic arch, you can see the retrograde flow in the ductus at this very, very young age. So it is possible to make this diagnosis. I know Elena had showed us some really beautiful pictures. So here is the same baby at 26 to 34 weeks. This is this baby here. You can see again the very hypertrophied chamber. You can see a fistula over here, and then there's some tricuspid insufficiency. Here again, a very small muscle-bound right ventricle with a very small tricuspid valve. And then here's the last one. So this would be, these primarily are of the body of the heart, of the right ventricle. So you can see the inflow, it looks pretty normal, but the body is very small. Same with this one. In this particular one here, it's also that the tricuspid valve, so the inflow portion as well as the body, is very small. So the coronary circulation in pulmonary atresia and intact septum, I kind of alluded to that this was really the discriminating factor between tricuspid atresia and pulmonary atresia, and what made the outcome so much poorer in pulmonary atresia and intact septum. So these anomalies occur in 36 to 75%, so really a huge number, and there are really a couple different types of them. They're ventriculo-coronary connections. The myocardial blood supply originates in the cardiac lumen during the pulmonary valve development, and you can either get sinusoids or fistula, or what we really worry about are the right ventricular coronary artery connections. And those are important because they need the high pressure to supply blood flow to the coronaries. You can have absent proximal aortic coronary connections, so the coronary arteries don't even attach to the aorta, or you can have stenosis or interruption. This is an example of a very early fetus that had a very large coronary fistula right here. You can see it along the wall of the right ventricle here. This was the flow in it, so a two-furrow flow, diastolic antegrade flow, just like it should, but systolic retrograde flow. So when the right ventricle contracted, the blood went backwards through the coronaries. So a very, very ominous sign. This baby also had proximal dilation of the coronary arteries, which you can see right here. You can see blood flow in it, and at this early age, you really shouldn't be able to see that. So you should look carefully for those because they impact the prognosis significantly. And in fact, if we see these before birth, babies all undergo a cardiac catheterization, and often we don't even try and do anything with them. We just list them for transplant because the outcome of doing any type of palliative surgery is so poor. So here's just an example, not a fetal example, of a cath showing the coronary anomalies. So here's the right coronary artery. This is a normal patient. Right coronary artery and the left coronary artery branching into the LAD and the circ. This is the aorta, head's up here, feet are down here. And this is a child with pulmonary atresia intact septum, and they're not injecting in the aorta, so they're not doing an aortogram, but they're actually injecting in the right ventricle. And you see when they inject in the right ventricle that you see the coronary arteries filling retrograde. So here's the LAD, and here's the circ, and there's no even connection to the aorta. These are just sort of in the right ventricle, and they don't even go to the aorta. So these are patients who will only survive with a transplant. So just some examples of the coronary artery fistulas here. That's kind of a quick view right there. Here's another one here. You can see the origin of the right coronary artery as it starts to go through the AV groove. And I'm not sure why I showed this one because there's no coronary arteries in that one. Sorry about that. All right, so we'll turn now to obstruction to systemic blood flow. Not enough blood flow, inflow, not enough outflow. So you're talking about a problem with the mitral valve, a problem with the aortic valve, or a problem in the transverse aortic arch. The hallmark of this is retrograde flow in the transverse arch, right? You still have the ductus going from right to left like it does normally, but it supplies blood flow in the transverse arch, and if there's severe hypoplasia, even in the proximal transverse arch. And you see here the red flow that is in the transverse arch, which you can see over here, is pretty small. And then you can see this in the three-vessel view as well. The red flow here is the red flow in the transverse arch, and the normal flow is in the pulmonary artery. So the most famous one is hypoplastic left heart, and I think Dr. Moon-Grady talked about that enough, because you can never see too many great pictures, or pictures, I won't say mine are great, but they've been carefully chosen. You can see that even at 13 weeks, you can see that this left ventricle is in trouble here. It's very dilated. There's a big wad of endocardiofibroelastosis right in here, all this brightness, and the right ventricle is vainly trying to help. You can also see another really good trick is to use color Doppler. You see that no color fills that left ventricle, and there is mitral insufficiency. So even at 13 weeks, this fetus is in trouble. This is at 15 weeks. You see the brightness around the papillary muscles of the mitral valve. And in this patient in 17 weeks, you see what's become sort of the left ventricle. We saw this patient this early, and we weren't sure if this was a big thrombus or what it was, but it just turned out to be a very hypertrophied and kind of calcified left ventricle. This is later on for this fetus, and you see that the left ventricle is probably the same size as it was here. It kind of looks the same, but everything else has grown around it. And then again, this is just showing how the color flow can be helpful in seeing what's going on in the physiology and the blood pressures in the left ventricle. So Dr. Moon-Grady talked about this too, the intact septum, and that if you have mitral atresia or severe mitral stenosis, the blood has to go backwards, so from left to right into the right atrium. But if this is restrictive, or if it's intact, then there's really no place for the blood to go. So it just kind of sloshes back and forth. This is an example of an intact septum right here. You can see that the pulmonary veins are quite dilated, and there's really no flow going across the septum. So we'll now talk about the classical single ventricle. I wish I could stop and ask for questions, but we must press forward. So the classical single ventricle is a double inlet left ventricle with a small outlet chamber and what we call a bulboventricular foramen. And you could say to me, well, that's just another example of cardiologists using different names for the same thing. Why can't you just call it a VSD? And your point is well taken. It goes back to how well we used to describe things before we could do anything about them. But if you think about it as a VSD, that's fine. It's just a really small VSD. The relationship of the great arteries are usually that from the small chamber comes the aorta in a detransposed fashion. If it's the pulmonary artery that comes from that small chamber, it's called a Holmes heart. So here are some other functionally single ventricles. The first is a double outlet right ventricle with a remote VSD. So a lot going on here, but let's look at this picture. Here's the larger right ventricle here, the smaller left ventricle. Here's the large right ventricle, small left ventricle, pulmonary arteries here, big aorta. And you don't really see a VSD in the typical place. It looks like it's down here somewhere in the muscular septum. So this would be a functionally single ventricle. No way that you can make this left ventricle a functional ventricle. Double outlet right ventricle with mitral atresia. Here is the right ventricle here. The left ventricle is very, very small, and so small you can barely see it, yet the aorta and the pulmonary artery are reasonable in size because they both come from that right ventricle, so double outlet. And then the severe Ebstein's anomaly here, or this is an interesting Ebstein's variant. You see that the valve is plastered way down here, but the ventricle is quite normal looking. This Ebstein's valve was non-functional, so it didn't even leak. So this patient was able to undergo or never developed a circular shunt, I should say. All right. Here's more on the double inlet left ventricle. So here are the two AV valves going into the single ventricle here, and the aortic, the pulmonary artery coming out. Here's one AV valve. Here's the second one, and you see the single ventricle here. Here's the small outlet chamber, which gives rise to the pulmonary artery here and the aorta. You see how you could be fooled by this, how it looks initially like a normal ventricle, but you can only see one of them. And then when you scan more anteriorly, you start seeing the great vessels, and you see, in fact, that both of the AV valves enter the double inlet ventricle. And then here's the transposed great vessels here. And this is really nice looking at the left ventricle here, and then the pulmonary artery coming from the small bulboventricular foramen here, and the small chamber up on top. So that is a double inlet left ventricle. Oops. Okay. Another type of single ventricle is the unbalanced AV septal defect, and Dr. Yagi gave a really nice talk today on the complete AV canals. When it's complete, there's a primum ASD, an inlet VSD, and an AV valve with 5 leaflets, and this has both VSD and ASD physiology. Now you can have differences in the sizes of the ventricles, which mostly have to do with how the AV valve opens up. And you see in this patient with a left dominant AVSD, right? This is left here. Here's the crux of the septum, and here's the small right ventricle. You can see what's happening here is that this AV valve is opening almost completely into the left ventricle. There's very little that opens into the right ventricle, and that's what causes the right ventricle to be hypoplastic. So an AV septal defect, but would probably need a shunt, or if not a shunt, directly a Glenn, and then a Fontan palliation. So, as Dr. Yagi also said, that usually the straightforward AVSDs go along with chromosome abnormalities. If you have an unbalanced one, think heterotaxy, chromosome abnormalities, or normal chromosomes. It's going to be one of those three. And I love this quote by Julian Hoffman, who is a cardiologist who's now passed away, who said the number of cases of right atrial isomerism, which is, is one type of heterotaxy, that do not have a univentricular atrioventricular connection, otherwise known as an AV septal defect, obstructed total anomalous pulmonary venous connection, pulmonary atresia, and transposition can be counted on the fingers of a very mutilated hand. So as Dr. Yagi said, if you see an unbalanced canal, look for heterotaxy, because more than not, you're likely to find it. If we look at this chart comparing the cardiac findings in heterotaxy between right atrial isomerism and left atrial isomerism, we see indeed that Dr. Hoffman was right. Lots of these patients will have AV septal defects with right atrial isomerism, but a fair proportion with left atrial isomerism will also have AV septal defects. So our group this last year decided we'd look at our fetal single ventricle population over the past 10 years from 2013 to 2023. And this all came because I couldn't get a straight answer from our surgeons as to how many of our patients required G-tubes, our single ventricle patients required G-tubes, and how many of them required feeding tube, just G tubes. So we decided we'd check the data ourselves. So we first looked at the fetal factors, and we found these things, that there was no difference in gestational age diagnosis between hypoplastic left and hypoplastic right, that fetal growth restriction was very common, 1 in 5, and this occurred with both hypoplastic left and hypoplastic right. About 5% died in utero with intent to treat. We had some preterm deliveries, about 57%, but the only severe preterm deliveries were 2.5%. A planned C-section was performed in about 23%, and about 14% had an unplanned C-section. Urgent cesarean delivery for non-reassuring testing was only in 5% of the total cohort, so not too bad. These were the maternal comorbidities we found. And you can see that a lot of them did have hypertensive disorders. There's a fair proportion that had weight issues, but there weren't a lot of differences really between hypoplastic left and hypoplastic right, which was a real surprise to us. Also, same thing for hypoplastic left and hypoplastic right with other maternal problems. Again, no real difference in the mothers. In the fetuses, same thing, no real differences in twins, fetal growth restriction, problems with amniotic fluid, or any extracardiac anomalies. Again, a little bit of surprise. I think maybe it's just bias, but I think all of us sort of think that hypoplastic left heart is the worst and much worse than hypoplastic right heart, because if you have a left ventricle, you should be okay. Turns out they're all pretty much the same. A lot of fetal growth restriction, and that needs to be delved into further. I know Alfred and several others have been doing some amazing work looking at the placentas of mothers with congenital heart disease, and they're finding a lot of abnormalities, and I look forward to hearing about those. So of 201 who had a fetal diagnosis, 15 mothers underwent interruption. There were 9 deaths. Of the 177 live-born, 14 died before a procedure. 6 were transplanted. Of the 157 who had a stage 1 palliation, that is a Norwood procedure or a BT shunt, there were 10 deaths and 5 transplants. And as you keep on going down, there's a little bit more losses until you get to the stage 3 Fontan. And if you've made it that far, you're likely to do very well. So in summary, we may have reached the pinnacle for surgical intervention for single ventricle cardiac defects and need to focus much more on maximizing neurodevelopmental outcome and long-term post-Fontan care for our patients. Although genetic testing was underutilized in this cohort, 17% with single ventricles have chromosome anomalies, and this may be even higher if we use whole exome or whole genome sequencing. Comorbidities for fetal single ventricle disease, focusing on what can be changed, and in utero intervention and treatment are the next goals for these pregnancies. So thank you very much for your attention.